Dr. ANASUA?
अच्छा उतना काट दिया था वो आ गई. Thank you.
Good afternoon, everyone. So I will be presenting a case series on multimodal imaging of Coats disease with macular nodule mimicking retinoblastoma. So in 1908, Sir George Coates first reported a case of Coats disease, which is a congenital retinopathy in young males characterized by idiopathic retinal telangiectasia, subretinal exudation, capillary non-perfusion areas, retinal detachment. Macular nodule is a well-recognized but poorly understood manifestation of Coats disease. In the Western literature, it ranges from around 23 to 53% of cases of Coats disease. However, interestingly, in Indian, the papers on Coats disease from India, none of them talk about or report any case of macular nodule in Coats. Like this particular patient, including 280 patients, none of them has been reported to have a macular nodule. So we looked into our 339 patients with Coats disease, and we found these were all treatment naive cases, and we found only 7 of them had a macular nodule. That is, only 2% of them had a macular nodule at presentation. We went ahead and documented all these. So the mean age of patients of Coats disease with macular nodule was 6 years. All of them were male. It was unilateral in all of them. The median best corrected visual acuity was CFCF, and all these patients were diagnosed with retinoblastoma and referred to our ocular oncology clinic. The most common presenting complaint was decreased vision, followed by squint and white pupillary reflex. The macular nodule was located at the fovea in majority of cases, and also between the superior arcade and fovea. The color was grayish white. It was either dome-shaped or bilobed with subretinal exudation around the nodule in all the cases. There was pigmentation in a significant number of them. The second or third order retinal vessels entered the nodule and continued till apex. 1/3 of them also had calcification. The periphery showed the typical telangiectatic vessels in all of them, most commonly being in the superiotemporal quadrant, along with exudation and subretinal fluid. Optical coherence tomography showed them as a well-defined subretinal hyperreflective nodule involving the outer retina, RPE, and Brooks membrane. There was disorganization of the inner retinal layers. The ellipsoid zone and ELM were disrupted. There was posterior shadowing surrounding exudates, but no fluid. Dense localized hyperreflective areas of RP aggregates were also seen. On ultrasound scan, it was an eco-dense mass with highly reflective A scan on the surface and inside the nodule whenever the calcification was there. On fundus fluorescein angiography at the macula, early hypofluorescence with the focal leakage was seen with late staining, and at the periphery, the light bulb aneurysm along with CNP areas were noted. The primary treatment was laser photocoagulation in majority, and the patients with retinal detachment also underwent scleral buckling and SRF drainage. At mean follow-up of 8 months, the BCVA was maintained in all cases with no significant gain. So just summarizing the differences with the macular retinoblastoma, these patients have xanthochoria. It is an older age group. They're all males, unilateral, whereas retinoblastoma is in a younger age group, and the AC and vitreous might also have seeds and hemorrhage there. So the clinical appearance is different, like it is a grayish white mass. You will see the surrounding exudation. There can be pigmentation vis-a-vis retinoblastoma, which is a fluffy white mass with feeder vessels and calcification. The periphery gives away the diagnosis with those telangiectatic vessels and exudation. On OCT, it is a subretinal nodule, whereas retinoblastoma involves the full thickness retina. On fundus fluorescein angiography, there will be blocked fluorescence because of the exudates and pigmentation, and periphery will show the light bulb aneurysm and CNP areas, which won't be the case in retinoblastoma. Ultrasound will show the presence of calcification chances are much more in retinoblastoma. Thus, to conclude, this is the first Indian study on Coats disease with macular nodule. It represents a vascular process and has an extremely low incidence in Indians. This is the first study to describe layer by layer the OCT changes in such patients. The poor visual prognosis in these cases is basically because of the extensive degenerative changes at the macula. It is of utmost importance to be aware of the typical fundus appearance and adjunctive imaging features of this entity to differentiate it from retinoblastoma and treat appropriately. Thank you for patient listening.
Thank you for a very nice study and very well documented. I think what we have been seeing is later presentation of a macular sort of a raised lesion, which is not typically what you probably by that time it has scarred, and not really what you picked up in the beginning. I think that is not uncommon. If we put those cases together, I think they may be all similar to what your cases are, but very well documented study.
Completely agree, sir. So during the course of the disease, many of them will develop, but what we have captured here are all treatment-naive cases at presentation.
That's what I'm telling, that it's not that uncommon, because we find many of these with poor vision is because of this macular large
Yes.
mound, which we see later, which is like a scar, not like what you presented. So maybe it is not that uncommon. Maybe we started looking at them more carefully now, and earlier how the eyes were enucleated, maybe we were not even looking at them that seriously, and probably the imaging modality was not available. Once the OCT was not there, many of them were, like for old-timer like us, many were enucleated, and this was the commonest cause of enucleation, which was mistaken, because that time the enucleation was very commonly done for retinoblastoma.
Yeah, completely agree, sir.
I think it's a reasonably good contribution. Only thing is that you in coarse disease you do not see an isolated macular nodule. You
True.
see always surrounded by exudation. Whereas in retinoblastoma, it may or may not be exudation may not be isolated nodule may be there, but surrounding exudation may not be
Yes.
there. Plus, no diagnosis without the periphery examination which clinches. Plus, very important is that OCT. Even if you are not very well versed with the indirect and don't see, then OCT can definitely help you out.
Yes, sir.
It was excellent documentation.
Yeah.
Whatever I think fundus finding and documentation, it was just excellent.
Thank you.
Thank you, Dr. ANASUA, for the excellent presentation.